So I'm going to talk about the bone block procedure, then the distal clavicle as a graft. And I must say that I'm a Latarjet fan. I'm a big fan. I was trained for 2 years in South Africa with Joe de Beer. So we did a lot of open Latarjet cases, and then later on I did Latarjet arthroscopically. And I agree with you, it's a perfect operation and it's very efficient. But it's like wearing a winter coat all year because you then never will be cold. Okay, so let's start and I'll tell you why I'm doing this. I'm not going too deep into the complications of the Latarjet because I think there are more talks in the later session who will go into detail, but we all know it can be a complicated operation, and you showed you did a very good job. You can do it efficiently and you have a low complication rate, but that's not for everybody, and that's, I think, the problem with the Latarjet operation. Quite a lot of complications and high osteoarthritic changes. And the osteoarthritis is maybe not only due to the operation, maybe also the natural course of the instability patient. But that's, for me, can be a problem because we all know that it can be difficult to do a next operation after a Latarjet. So if these patients in the future need a total shoulder arthroplasty, it can be really a difficult procedure. And you can discuss and fight with each other if you want to do it open or arthroscopically. I don't care, because the main disadvantage, I think, from the Latarjet is the fact that you transfer the coracoid. Therefore, the brachial plexus is open in the wound. It will get close to the scar tissue, and that can be a potential danger for future operations if you have to go in. Okay, so why is it important? Because we don't have to do that many re-operations, but I'll show you some examples that I have from over the last year in the Netherlands, and the Netherlands is also, I think, a developed country. Just check, sorry, this one. Yeah, so just show you examples. And this is really within a couple of months it came to my clinic for second opinions. So look at the bones. And not even all were done arthroscopically, but even open surgery. Young guys, 22 years. This guy was 28 years. Next guy, 24 years. The screws were wide and open into the glenoid. This was actually an open case. Again, you can see that they think the report is that it's okay, but you can see the screw head is really getting into the humeral head. This guy, CT scan was made on the same day as the operation, and they said it was a good position of the graft, whereas I think this should really be corrected immediately. Otherwise, you end up having this. And this is the problem, you know, this is guys, 28-year-olds with extensive osteoarthritis, really bad situation, and nobody really knows what to do. And I know, as you said, Sean, the sling effect is really an advantage of the Latarjet, and I totally agree with you. So especially for the patients with hyperlaxity or bad soft tissue, it is an add-on. But I wonder if it's necessary in all cases. And especially now that we have these articles coming out comparing the bone block with the Latarjet, we actually see that the clinical results are not that bad and actually show the same type of recurrence. Okay, it's mid to long, of a early to midterm results, but still. Also, if you look at the reviews, the amount of recurrences are more or less the same. You can do it arthroscopically, of course, that we all saw this morning, and some good articles. The one from Boom from Germany showed with the autograft there was a lot of resorption of the bone, but with the autograft it was much better, and also published with a nice series of Manos with the endo button. The only thing is, as Jean also said, there can be problems with the harvesting of the iliac crest. So a lot of complications has been described, a lot of pain, nerve and sensitive sensation problems, and scar formation. So I think if you can avoid it, it would be better. So the idea I had when I worked in South Africa was to use the clavicle And I wanted to go through the interval, so make a large bone block, and then put the medial side of the clavicle graft against the bone, so you have cancellous bone against each other, and you have no or less donor side morbidity, because we all do Mumford procedures, and they do well after the surgery, and low cost, of course. So in 2014, Tokish published this article, but they used like an osteochondral allograft from the distal clavicle, and we decided to do the big graft, so with the bone medial side against the bone. So I started with the cadavers, with the MyTech system at that point, with the screws, because I was doing the Latarjet arthroscopically with MyTech, and I changed to the button system in 2016, after the reports and the results from Ettore. So just show you the technique. Very important is that you have to know, of course, that the ligaments between the coracoid and the acromion will be the ones that are withholding the bone block to enter through the rotator interval. So you must appreciate it, and you must cut it, otherwise you will pull your graft in two halves. So here you can see the picture. On the top you can see only make a split, so you don't clear out the whole interval. That's the difference with the iliac crest bone block. You only make a split, and you will see the ligaments where you also make just a split. And then you prepare the bone. I think it's good to make a nice bleeding surface, because we really want to have cancellous bone against cancellous bone. I think this we saw already in the nice videos this morning, so we can speed it up. So this is the same device. You make two sutures that come out of the wound, and I take them out of the superior portal. Now this is what I do then. So I've prepared the glenoid. And then I feel the edge behind the distal clavicle and the acromion. So that's the point I'm going to give my skin incision, and I start right at the portal, so at the cannula. So you just extend it, and you feel with the needle just exactly where the capsule is. You open it, you make a T incision, and you just prepare the distal clavicle, like you can do for a normal distal clavicle excision. Then you check with the osteotome to see the line of the surface of the articular surface, and in that line you will make a cut with the saw, and then you can take it out. And you can take it out completely, and my experience is that normally if somebody has a large glenoid, the distal clavicle will be accordingly. So you can have sometimes smaller glenoid, and now I'm opening the interval with my finger. So this is the open part, and I'll show you why I do it, because here you prepare the graft the same way as with the iliac crest. And on the next video, you'll see that I reposition the arm. The head must be really in the joint. The wound is still open, and you don't pull that hard, so I push the graft into the opening. And that's also an advantage, because if you just can pull and there's no open wound, you can maybe break the graft. So I just used the portal and the wound where we took the graft from. Now it's inside, we can see it's on the right position, and we check it by just putting in the scope intra-articular. So the wound is still open, so I just want to make sure that it's really in the right position before I tie the buttons at the posterior side and start closing the wound. And in Holland, we're very good in the water management, so that's what we want. We want to have a watertight wound so we can continue with the final part. At the end, we already put in the anchors. It's just a matter of repairing the capsule. You can see the bone block is nice in position. So just for the time, I will continue. These are the scars, only a small incision on top, and the normal scars from the arthroscopy. And the results so far, so I did the first 7 with screws. So now I've done a total of 66 patients since 2015, 59 with the endo button, and 45 of them I have a 2 years minimum follow-up, so 2 to 7 years. So the age was quite high. You can see a patient was 70, was a very active guy who was ice skating, had a huge bone defect, and dislocate the shoulder. So in that type of guy, maybe he will develop soon afterwards osteoarthritis and need a total shoulder. So now all options are still open. Already a history of long time dislocations and many dislocations, and the bone loss was 13.2. Also patients with 0%, because those were the ones who had a Bankert previously. One is lost to follow-up. He moved abroad. We cannot find him. With 44 patients, of them had a near or full range of motion at the latest follow-up, and the apprehension was negative. And we are all getting them in this summer, also because we want to have CTs from all patients. One patient is still struggling now, 2 years, with the frozen shoulder. Although it's in the thawing phase, she's still not 100%. 2 redislocations, one 6 months or 7 months with a severe crash with a mountain bike. Oh, but I think, you know, you must see it as a recurrence. Anyhow, and one's just doing bench pressing, but he was actually hyperlax. So I think the indication was not right. No patient complained of the AC joint area, and one patient had pain posterior, but that subsided after a while. 2 patients had epileptic seizures, where both had the other shoulder dislocating. So both the operated ones were stable. The average dimensions of the distal clavicle are actually good enough for a bone block. And if we look at the CTs, we have 30 patients already done for the CT. There was some resorption in 17, 1 had a medium, and 2 had complete resorption, and those were the ones that had a recurrence. Position was okay, 1 really too high, 4 slightly high, 26 in good position, and the width of the grasp was, after the surgery, about 30% of the diameter of the glenoid. And we know we can repair. There's also a nice article, but they looked at the osteoarticular size of the distal clavicle, and if you can see, they say the coracoid from the Latarjet procedure gives a better how do you say it? It gives a better congruent articular surface, and the distal clavicle is smaller. But if you rotate the block, so you put the medial side against it, you're coming also to 30%. So it's about the same. Sorry, otherwise you're probably knocked out by sleeping because of my long story. But anyways, I think it's a good in-between option. So for the summertime, when you take off your coat, you can do this procedure. So no bridges are burned. You can use a large block, and by doing it via the interval, via the open way, you can use it without too much damage. Put the medial side against the clavicle, against the cancellous bone, and you make it extraarticular. The subscap remains intact, and I think much lower risk than the Latarjet. Thank you very much.